everyone. My name is Jodi Lyons, and I'm your host for Your Need to Know. Today, I am absolutely thrilled to be here with Dr. Ketan Petal, who's an affiliated physician with National Spine and Pain Center. Our goal today is to talk to you a little bit about pain, what it is, what kind of doctor you need to see, and how you can manage it with the help of your physician. So without further ado, Dr. Petal, I'm so happy you're here. Thanks for coming.
Thank you very much for having me. I'm really excited to be here.
Great. So first of all, can you just tell me a little bit about yourself, like where you went to medical school and all of that, and then most importantly, why you became a doctor?
Sure. So currently I'm an executive physician at National Spine and Pain Centers, and I do have a few other roles. I'm the medical director for the Haymarket, Virginia office, which is where I primarily practice. I'm also the co-medical director for the Virginia region, and I also have a unique role of being the director of advocacy for the organization.
So what does that mean, director of advocacy? I'm a policy wonk, so immediately that's the thing I picked up on.
So this is something that's really important to me, and it gets me really excited.
Okay.
You know, as physicians, we're very busy treating patients all the time, and we don't always get the chance to really be involved in a lot of these policies that affect patient care. And in my world, in the interventional pain management world, there's a big need for that because of a lot of the policies that are being written out there and a lot that have occurred in the past few years. So what I do is I try to act as a conduit for the other physicians, the 100+ physicians in our organization, to bring to them important matters so that we can work together at a grassroots level to enact change to help our patients.
That's terrific. Can you give me an example of what sort of thing you've needed to advocate on? And I'll tell you, I'm going to bring up the ugly thing first, which is everybody talks about the opioid crisis, and we understand how important it is, but I don't think people understand there are other things you can do, and I'm sure it affects your business. So can you tell me a little?
Absolutely. And so as an interventional pain management physicians, we provide a gamut of treatment options. And occasionally medications can be a part of it, but it's sometimes a very small part of what we do. In fact, what we do can help these type of situations, such as the opiate epidemic that we're in currently. A lot of what we can do, some of it's interventional based, some of it's working with other type of practitioners, physical therapists and surgeons to try to treat the patient's symptoms, both with pain and allow them to be more functional.
That's excellent. So now here's the million-dollar question. Why did you become a doctor?
That's an interesting one. I can spend probably an hour talking about why that is, but you know, really, I think what it comes down to, and this is something that someone told me and it really stuck with me, is that it's the most intimate relationship you can have with a complete stranger.
I love that. That's
and so
great.
If you think about it, you know, we can say I want to help people. Well, that's true of really many of the professions that are out there, right? We all help each other. But to me, it was also the science and all the data behind what we do and be able to perform certain treatments for individuals and get them out of suffering, right? That's what we do as physicians, is to treat people, not just their medical conditions, but help their suffering and their pain. And that's really what drives me to do what I do.
That's wonderful. And so that explains why you became a pain management specialist, right?
That does,
and
yes.
Was it a straight path from you went to medical school and then you became a pain specialist, or what steps did you take along the way?
So I went through a few different steps, but a lot of what I did was starting when I was in high school. And so I kind of knew, I had a sense that I wanted to do this. And so I was very fortunate that I was actually accepted into a 7-year combined BSMD program in upstate New York. So I went to undergrad and then straight into medical school right thereafter.
Okay.
And so I was able to finish both of those in 7 years. And then that took me to further training in anesthesiology. I was at Johns Hopkins Hospital for the next 3 to 4 years. And so I feel very blessed because I had such an amazing experience there, working with some of the most renowned people in the world. It was really a cool place to be.
Yeah.
And then that took me to the West Coast, where I went to UCLA to do further training and subspecialize in pain management. Now that's 11, 12 years ago, and I still love what I do every day.
That's wonderful. Is there anything else you want to tell me about where you practice, how people can get in touch with you? Because I'm sure by right now people are saying, hey, wait a minute, this guy might be the one to help me.
Absolutely, and I would say me or any of the other physicians that work with me, we feel very privileged to be able to treat the people that we treat. So I currently practice in the Haymarket, Virginia location, which is in Prince William County, not too far from where we are here.
Right.
And so I have a lot of patients who come to us both locally as well as from the region. And so anyone who wants to be treated in the Northern Virginia region, with either myself or my colleagues, we're happy to do our best to help them out.
Great. And this may sound like an unusual question, but does someone need a referral from a primary care physician to come see you? And there may be two answers. It may be private insurance and then a Medicare answer.
So what I would say is that for any individual who wants to be seen, call us or go onto our website and schedule with us. And then we can typically take care of the rest. Now, some of the nuance in terms of whether referral is needed or not will come down to the individual coverage that the person has.
Okay.
For many of the audience, especially if they have Medicare, generally a referral is not needed. So they can come see us and we're happy to help them out. And if they do need a referral, then we can help them out with that as well.
That's excellent. Thank you. I appreciate that. And I know that's the first thing people say is, well, how do I pay for it and how do I get to see the doctor?
Absolutely.
So another question for you, and it may sound rather basic, but what is pain in general, and what is the difference between something hurts versus they need to see someone like you?
Absolutely. So obviously everyone has pain. You know, whether you stub your toe or whether you've had multiple back surgeries, pain is part of what we live through on a daily basis. Now, pain is generally a good thing. If you hold your hand above a flame, it's going to tell you to withdraw your hand, right? But when pain becomes dysfunctional, when pain starts to inhibit your ability to do what you want to do, that's the trigger to go see someone.
Okay, that makes a lot of sense. So it's basically something that interferes with your ability to function on a day-to-day basis.
I would keep it that simple. To me, I'm a very simple guy.
I like that.
I like to keep it simple. If it's preventing you from doing what you want to do, that's the time to look into it.
So what sort of things cause pain? I know everybody immediately thinks of knee pain or back pain.
Yeah.
But what is it really?
Pain is very complex. There's many different types of pain. So, the knee pain and back pain, there's certain terminologies that we use. I won't get into too much detail, but we call it nociceptive pain, which is some things that are broken or something's dysfunctional, and then the nerves are transmitting pain to the brain to register it as, hey, something's not right here.
Okay.
Let's do something about it. But there are other types of pain where the nerves themselves could be damaged, or someone can have scar tissue that's causing pain, or there may be other types of changes in the pain pathways in the body that can cause pain and dysfunction. So there's a lot of subtleties within pain. But as a general rule of thumb, there could be a lot of reasons why someone could be in pain.
So how would you start? Let's say somebody comes in and they say to you, my arm hurts.
Well, so
what do you ask?
When we go through medical school, the first thing that we look at is taking a good history and doing a good physical exam. In as much as we use diagnostic tools such as x-rays and MRIs, that's the foundation, is understanding the story and understanding what happened that caused this. And then doing a really good exam to understand and corroborate what we found out when we took that history. And so to me, that's where we start. When did the pain start? How did it happen? How long has it been going on? What have you done to alleviate it? So on and so forth. And then doing a thorough examination to glean more information so that you can decide what is the next step. Do I send this person to physical therapy? Do I need to get an MRI? Is there a procedure that I need to consider? So it all starts with that foundation.
So there's a decision tree that you're going through. And if I'm hearing you correctly, patients should be educated about their own bodies when they come in to see you, to say, this is what I'm experiencing, this is how long it's been happening, this is what I've tried, this is what has worked, this is not what has worked, or what has not worked, instead of just walking in and say, my arm hurts, right? So the H&P, the history and physical, is really important.
It is important, but I would tell folks, you already know that information. It's not something that you have to do homework on before you come see me. You know that. You may come in and say, my arm hurts, and I'm going to ask you questions. Well, when did it start hurting? Oh, it started hurting a few months ago. So it's stuff that you already know. And just teasing out that information can help a long way in formulating a plan to get them to the goals that they want to reach.
That's cool. I really appreciate there's a real thought process there that I think people don't know exists. Now, when we talk about pain, and as we said, people always think about their back and their knee, do migraines fall under that category, or what other sorts of conditions do you treat that would fall under the umbrella of pain?
It's funny, at our organization, we have a saying that we treat pain from head to toe.
Okay.
And it is true. I would say that a lot of what we do is spine. I mean, spine is in our name. But I would say that's probably 80% of what I see, but I see all sorts of pain, anywhere from headaches to, someone had surgery on their foot where they're having difficulty with ongoing pain. Folks who have neuropathy, maybe it's related to diabetes or some other condition. So we really do treat quite a gamut of symptoms.
That's amazing. It's a world I think a lot of people don't know a lot about. And
Yes.
I'm afraid to say that I think probably a lot of primary care physicians and other doctors don't really understand what it is you do and where you fit into their whole team.
Absolutely, and part of what I do also is I educate not only patients and other members of the community, but I try to do my best to also educate other providers, whether it's primary care physicians or other practitioners of medicine. And part of that just has to do with we weren't really trained to know about this when we were going through our training in medical school. And so it is, as a field, interventional pain management's a few decades old, right, compared to some of the other type of specialties that are out there. But we have had such an impact on patients and outcomes over the past few years, and we have a lot of data to support what we're doing. And I always like to look at it this way. If we look at how we treated cardiovascular disease decades ago, the first person you would go see is a cardiothoracic surgeon, and then they would schedule your surgery. Well, look at what happened as cardiology started to become more involved in all the studies and papers that came out, and also a lot of the interventions that they were able to provide allowed folks to avoid surgery in many situations. And so, and we have there's a collaborative effect, right? There's a collaboration between the primary care, the cardiologist, and the surgeon. Well, we're doing that here, and let's take the spine as an example. We're able to treat not only the symptoms, because I think that there's sometimes a misconception that we're only masking pain.
Okay.
Now we're starting to delve into, and again, I can go on for hours on this, we're starting to delve into, and there's more data that suggests that many, especially some of the new things that we're able to do, can be disease modifying. What I mean by that is it's not just controlling the symptoms, but we're now able to delve into the category of treatment where can we change outcomes for our individuals. And I think that we're now going to be transitioning to that, and there's going to be more to come.
I think that's great. And remember that point, because we need to stop now for a break. And when we come back, I'd like to talk more about disease modifying and the rest of that. Everybody, thank you for joining us. We're going to take a quick break, and we'll be right back.
Maria, so how's work?
It was fourth period biology. Our students just weren't getting how easily viruses spread. So Miss Bella and I had them role play a zombie virus outbreak. By the time they had all learned the lesson, all the living were dead. Hey, how's your job going?
That big sales meeting I planned? Next year, I might get to go.
Cool.
When I was your age, I was just like you, fascinated by stars. But now I get to search for life in the universe. And who knows, maybe life is looking for us too.
So we're like aliens to them?
Yeah. Does anyone want to be a scientist now?
I do.
Awesome. We need more girls in STEM.
Maybe we can find aliens.
Caitlin, be serious. No, take the oath. Come on. I'm totally taking this seriously. Okay, I'm ready. You may begin. I pledge that I will never meet in person with anyone I first met online without checking with my parent or guardian. And furthermore, if my parent or guardian agrees to the meeting, it will be in a public place and my parent or guardian must come along. Do you pinky swear? I do.
When you teach your kids about internet safety, they'll pass it on. For more information, go to cableclicksmart.org.
Opiates has taken everything and everyone I've ever loved away from me. Everything.
I blew my ankle out and I got prescribed pain pills by my doctor.
If making my detox public is gonna help somebody, I'm all for it. I just wish I would have had a warning.
Opioid dependence can happen after just 5 days. Know the truth, spread the truth.
Hi everybody, welcome back to Your Need to Know. My name is Jodi Lyons, and once again I'm here with Dr. Petal, and we were just talking about disease-modifying treatments for pain before the break. We're just going to get into this really briefly, and then we'll move on to what's not the newest and shiniest. But can you tell me a little bit more about disease-modifying treatments?
Absolutely. In the past few years, there've been a lot of work out of Harvard actually on certain procedures and novel procedures, to the point now where CMS, who makes all the codes for the types of procedures, had actually come up with new codes and new diagnosis codes. So,
oh, that's excellent.
I'll give you an example, and I won't delve too much into it because it's so new that we're going to learn more in the near future. But for individuals who've had chronic back pain, the muscles in the back start to weaken. And so what happens is now you lose that muscle tone, and it puts a lot of stress on your back. And so what we can do now is you can put in electrodes to stimulate the nerves that stimulate those muscles and allow them to recover. And because of that, you're able to protect the spine. And potentially, as further research comes out, we'll see that it could potentially affect how the disease progresses for a lot of these individuals.
So that's basically electrodes stimulation of muscle. Is it internal or external?
It's internal, and it's stimulating the nerve that goes to the muscle, but it's, I mean, again, it's really fascinating, and there's a lot of research coming out, and I spoke actually to one of the principal investigators who's doing that. He's a colleague who's up at Harvard, and again, to me, it's really fascinating, really cool. It's coming down the pipeline. It's not quite here yet, but it's really cool.
That sounds great, and of course, new and exciting. And in the meantime, I assume there are more tried and true methods. So can you talk to me a little bit about more basic, and I hate to use the word basic, but let's try the word other methods of treating pain?
Absolutely. And I think the best way for me to share that with you is to walk you through what I would tell a patient who came into our office.
Perfect.
So it doesn't matter what type of pain that there is. I feel like treatment generally falls into 4 categories.
Okay.
It could be pain in your back, it could be a headache, it could be nerve pain due to surgery in the foot, whatever it may be, arthritis of the hip, anything. There's generally 4 categories of treatment. And again, this is how I view it.
Okay.
Other practitioners may have different views on it, but to me, the first category is always the conservative treatment options. And that can include things like medications, physical therapy, massage therapy, bracing, modifying activity, etc. And what do these things really do? Well, think about pain. A lot of pain comes from inflammation. And let's take the back as an example.
Okay.
You know, you may have some structural problems in your spine, but you know, you have days when you're feeling good and days when you're not feeling so good. Well, the structural stuff isn't changing, so what's changing? Sometimes it's the level of inflammation. And so if you focus on, for example, let's say physical therapy, strengthening up the muscles in the back, maybe avoiding type of activities that are going to trigger some of the back pain, that sort of stuff helps support the spine and cause less strain on the spine, which in turn leads to less inflammation, and that leads to less pain. And so those small types of treatments, anti-inflammatory medications, again, how do they work? They treat the inflammation. Now, I'm simplifying it a little bit. There's other types of treatment within that group, but as a category, that's all the simple kind of foundational things, to be fair, of which everything else builds off of. We have to do these things.
Okay, so
and we have to do these things in conjunction with anything else that we do, right?
So that's basically phase 1.
That's phase 1, and foundational, right? Because I always tell folks, these treatment categories that I'm going to tell you, they're not exclusive of each other. In fact, there's synergy, and I think it's important to understand that we still have to do the foundational things for many individuals. So now beyond that can include some of the procedures that we do. I'll give you an example. Again, we'll stay with back pain, just so it's a good way for us to kind of see where we are on the spectrum. So with back pain, there are many different types of procedures. Many individuals may be familiar with epidural steroid injections, or there's treatments to treat the arthritis of the spine. What these treatments do will be either to target inflammation. For example, if someone has a pinched nerve in their back, we can do an injection, and what that will do is wash out the inflammation, and the steroid can decrease some of the swelling in that area, and that can allow them to do more of those conservative measures, which will in turn help them out. If someone has arthritis of the spine, we can actually do a procedure where we can use a thermal probe to deaden the little nerves that transmit pain and it prevents individuals, and that type of pain prevents individuals from having a full range of motion. And by doing this, they're able to get more out of their exercises, improve their range of motion, and help with their pain. Now, that's a lot of the bread and butter, tried and true stuff. Now, there are other procedures that we have nowadays where we can target things to a little bit more detail. There are procedures where we can actually go into the discs themselves of the spine, and you can inject stem cells for the right patient, and these are your body's own stem cells, to be able to help increase some of the robustness of the disc that's perhaps lost some of its structure over time. We can actually do procedures where you can actually go in and deaden a nerve that's in the body of the bone that's transmitting pain from those discs that are problematic. We can go in and do minimally invasive procedures where we put a little bit of an implant either in the back, or we can scrape out some of that material through a very tiny incision that's the size of a baby aspirin. So there's a lot of different things that we can do nowadays. Now, with anything else, not every tool is going to be right for every individual.
It's not all a hammer.
It's not, you know, I have a hammer doesn't mean everything is a nail. It's really about understanding the specific situation that that individual is in and coming up with the right options for them. Now, I talked to you about two sort of categories.
Right.
The third one would be surgical options. You know, and what I tell folks, and I think this is where it's really important, is we need to understand why we do what we do. The why is just as important as the how.
Okay.
So for example, in back pain, I always tell my patients, there's generally two reasons why someone would need surgery. And those two reasons are, one is if you start to have neurological compromise, significant weakness, significant numbness, clumsiness, balance issues, where, you know what, it's not just about the pain anymore.
It's increasing fall risk and all of those other issues.
Exactly, and permanent nerve damage. And you know what, in those situations, sometimes you just have to get the surgery done to prevent further damage. And that's the absolute objective reason to do that.
Okay.
But for some individuals, if they go through sort of reasonable treatment options, those conservative measures, some of the procedural things that we can do, and if you do get to the point where, you know what, I'm not getting the sustained benefit that they need, then surgery may be an appropriate option if there's something identifiable that can be corrected. But again, that would be sort of that third group above and beyond those other ones.
Sounds like one of the big issues is, you just said, there has to be something identifiable that can be corrected to get to that point.
And here's what's interesting is, you know, we think about surgery as being this big ordeal, and yes, in many situations, that is absolutely what is needed. But again, nowadays we have tools. We can do minimally invasive surgical procedures for individuals with many types of pain. For example, if you have spinal stenosis, which is the most common cause of back pain for individuals over the age of 55, what that is you see all these individuals at the grocery store who have to lean over the shopping cart because they're having back pain and leg pain.
So that's the people leaning and they're not standing straight and things like that. Okay.
So sometimes we can go in and put in a little spacer as an outpatient surgery nowadays, and that can help address that the stenosis that they have, and sometimes we can help them avoid a larger surgery. Now, again, individualized care, you have to do the right thing for the person, but there are options out here now that people just may not be understanding that exists for them.
That's amazing. So can we go back to, for a second, the people we see who have been, you know, it's the stereotype of an older woman who's folded in half walking and looks like the letter V instead of the letter I. Let's use that as an example.
Sure.
What would you think immediately when you saw something like that?
So it's funny, if I go to the grocery store even on my own, I'm like, okay,
exactly.
That person has spinal stenosis.
Right. Yeah.
So we see it every day with the individuals around us. And I think what's perhaps unfortunate is people don't know that there are options out there. And I think, again, that's why I'm here today, is I want to share that with you, that there are options out there for individuals. And let's be true, not everyone needs every procedure.
Right.
I think some folks will do awesome with physical therapy. Some folks, I've done a few injections and they're good for years. And some folks will need something more invasive where I can do either that spacer or whether they need traditional surgery. And again, the key thing is being able to have that discussion with your care team and understanding what your options are and understanding when you should consider what option. And I think that that's the important part about what we do, is to help someone guide along that pathway.
So a lot of it is patient education, physician education, and working as a team and getting away from the assumption that you're going to, you know, cut open their spine, you know, all the way down the back or things like that. So that's probably an old technique people are afraid of.
And getting away from the assumption that all they have available to them is medications. I mean, there's a lot of things right now that have a growing body of literature to help them out. Now, I said there was a fourth category as well.
Exactly, and we've got about 3 minutes, so can you tell me about that?
So absolutely. So the fourth category is something that's near and dear to my heart because I do education on this, and that's implantable therapies. And that can include a few different options, including spinal cord stimulators as well as pain pumps. So for example, we can put in these implantable devices to control the pain. For example, a spinal cord stimulator can send signal to the spinal cord. And we think about it as electricity, but I can go into more detail perhaps another time, where it's actually changing the neurochemical signaling at the level of spinal cord and changing how pain is transmitting. I mean, it's very cool. I could go on for hours about this. Or a pain pump where we're delivering pain medication directly into the spinal canal. And again, these are invasive type of treatments, and so you have to really understand what the appropriate option is for a patient. And to me, with the last minute, I'll tell you, is I always consider those when three things are true.
Okay.
One is that there's nothing reasonable, conservative that can be done. Number two is that there's no reasonable fix, whether surgical or otherwise. And number three, it's for the individuals where, look, we can't fix the underlying issue, but let's do something about their pain and functionality. And I think when those three things are true, then a lot of times these options can be appropriate for the individual. And so that's really how I treat my patients. I mean, it's really about trying to understand where they are on the spectrum of treatment and understanding what's the reasonable next step. And I keep it that simple.
That is very simple and very much appreciated, because I think a lot of what you deal with is fear and misinformation. And again, it's not always just a pill.
Yes.
And it's also, there's something in between the pill and extensive invasive surgery.
Yes.
Which I think is huge. Now, we have about 1 minute left. Is there anything you think we missed that you would like to make sure that we address?
I think one thing I would say is that understand that there are options out there. If you're living in pain, you can do something about it. And the way I would look at it is this, again, I'm a very simple person. If the pain is preventing you from doing what you want to do and what you need to do, see someone about it. Whether it's going to your primary care physician or whether it's seeing someone who does something that I do. We can typically help you achieve your goals. And I would probably leave you with that.
I think that's terrific. And once again, everybody, I want to say thank you very much. And Dr. Petal, I can't thank you enough. For everybody out there, we've shown his website, and we know that he is out in the Haymarket area. There are other affiliated doctors with National Spine and Pain, so if you can't get in to see Dr. Petal, you can see some of his colleagues. And once again, we very much appreciate your watching Your Need to Know. Have a great day.